On the tail end of the perioperative study, the MAGIC trial with the ECF, Albatran presented an ASCO of 2017, a very compelling and game-changing study, the FLOT trial, which is a phase 2/3 trial, looking at epirubicin cisplatin 5-FU, which is the MAGIC ECF regimen, compared with FLOT. FLOT essentially is FOLFOX without the bolus 5-FU and a 24-hour infusion of 5-FU. And in addition to that, docetaxel or the T is added. And patients are given 2 months of chemotherapy with FLOT prior to the surgery and then 2 months after. What was really impressive was that was a higher pathological complete response rate with the FLOT regimen of up to 10 to 23% versus the 6% in the epirubicin cisplatin 5-FU regimen. And there was reduced grade 3/4 toxicity in the FLOT regimen. The data is still accruing, but it looks like there's been improvement in survival from 30 to 50 months, which is also a very impressive number, essentially making FLOT the perioperative therapy of choice if the patient would tolerate it. It is a 3-drug regimen. We're all very aware of what we do when we have 3-drug regimens over 2-drug regimens in terms of toxicity. So patients who do not tolerate the FLOT, I generally give FOLFOX to them in the perioperative period, which also has good data as a perioperative regimen that works very well.
Well, for gastric cancer, perioperative chemotherapy without radiation is an accepted global standard of care. And up until recently, the British regimen combining epirubicin, platinum, and 5-FU was the standard chemotherapy. The Germans developed the FLOT regimen, which is a modified FOLFOX with the addition of docetaxel. And they had promising phase 2 data and tolerance from their preoperative studies. They did a head-to-head comparison of FLOT versus ECF or ECX in over 700 patients with GE junction and gastric cancers, and the primary endpoint was overall survival. The FLOT regimen is given every 2 weeks for 4 cycles preoperatively and 4 cycles postoperatively, compared to the standard 3 pre and 3 postoperative cycles of ECF. This trial was well conducted. Patients had endoscopic ultrasound staging, many had laparoscopic staging, and the majority had T3 or node-positive cancers. And it was about a 50% distribution of GE junction and distal gastric cancers. This was a positive trial. Progression-free survival was significantly improved from 18 to 30 months with FLOT, and median survival was improved from in the 30-month range to 50 months with the FLOT regimen. All the other endpoints favored FLOT. There was a slight improvement in curative resection rate of about 8%, and there were more pathologic complete responses on the FLOT arm. So pretty much every endpoint favored the FLOT regimen. Also, slightly more patients were node negative and earlier T stage. So putting that together, in an appropriate patient that can tolerate 3-drug therapy, the FLOT regimen, I think, has become the new standard. It improved survival, improved surgical outcomes and response compared to ECF alone. So I think for a distal gastric cancer, the FLOT regimen should be the new standard of care. Toxicity management, the doses used on that trial were pretty high, and most patients, I think, will require dose reductions or growth factor support, but that can be individualized for each patient. There are always concerns that dose reduction may compromise efficacy. I'd have to say in 3 decades of practice, I've never seen that be the case. Most chemotherapy regimens are dosed much too high, and we accept way too significant toxicities. Appropriate dose reductions probably should be made for this regimen to try and minimize toxic effects.